Professor about this nice presentation. It is very apparent that his experience in the solar and solar thermal-based will be a matter of discussion at the end of this session. Once again, Professor Nagan, our eminent geologist, will give the second presentation. It will be about the current guidelines and imaging of the exam.
Thanks, Mr. Chairman. Thanks, my dear Professor Dr. Mohammed. For imaging of the axilla in breast cancer, for imaging generally in breast cancer, we need to diagnose the size of the tumor, the histopathologic grade, the presence or absence of lymph node metastasis at the time of diagnosis, and the number of involved nodes, the level of lymph node involved for staging. This is an important diagram showing the levels of axillary lymph node involvement, and the level of axillary lymph node involvement will affect the stage of breast cancer. Our landmark here is the pectoralis minor muscle. Lateral to the pectoralis minor muscle is the level 1 axillary, lateral axillary or level 1 axillary. Just below or behind the pectoralis minor muscle is the level 2 or mid axillary level. Medial to the pectoralis minor is level 3 axillary lymph node. So, meaning that when having infraclavicular, supraclavicular, internal mammary, or even intramammary lymph node, this is third level axillary involvement, and it can change the stage of the patient from stage 3A to 3B, and this is very important for management. The level 1, this is an example of level 1 axillary, which is lateral to the lateral axillary, lateral to the pectoralis minor. This is the pectoralis minor in ultrasound. You can find the pectoralis minor muscle just behind or just above the axillary artery. So you have to look for the axillary artery and then go above the axillary artery. You find the muscle. This is the pectoralis minor muscle. And then you can score your axilla. This is level 3 axillary lymph node because we have supraclavicular lymph node and infraclavicular or subclavicular lymph node involvement. When having internal mammary, this is of course level 3 axillary. The lymph node infiltration starts as the subcapsular region by nodules along the subcapsular channels entering the lymph nodes from the periphery. This is very important because in ultrasound we will know the importance of having nodule in the cortex now. It starts as nodules in the cortex and then spread to involve the whole node, giving the mass-like or the rounded appearance. For assessing the lymph nodes, we start by the physical examination. Don't forget to touch your patient, and then of course, we start by mammography. So axillary lymph nodes are almost always seen in mammography, diagnosed by being rounded in shape, dense rounded, void of fat lucency. When having the node of irregular outline, this indicates extranodal infiltration, and this will affect the stage of the patient. Ultrasound is the most sensitive method for diagnosis of lymph node. The two cardinal signs of lymph node involvement, the rounded appearance and the cortical infiltration. But you have to measure the thickness of the cortex. It should be more than 2.3 millimeters. This is the cutoff measurement. Because we usually see non-specific lymph node in the axilla in almost most of our patients. So not every lymph node seen in ultrasound is pathologic, but only we diagnose pathological lymph node if the cortical thickness more than 2.3, and this is agreed upon. To classify the appearance of lymph node, we have the mass-like appearance, rounded or totally infiltrated, or the diffuse cortical thickening, and I repeat, it's more than 2.3 millimeter thickness, and the nodular appearance, and now you know from where comes the nodule. The frequency of mass-like presentation to be infiltrated is the most, followed by the diffuse cortical thickening, followed by the nodular cortical thickening. The role of MRI in in diagnosis of infiltrated lymph node is not very important because it has a very variable sensitivity ranging from 56 to 92. In a meta-analysis, a large number of patients included in a large meta-analysis and metastatic and systematic review, they found that the sensitivity is 90%, but is very widely variable from 60 to 90%. And this decreases the role of MRI in commenting or diagnosis of axillary lymph node. Also, the BET-CT has the same situation. Regarding the axillary lymph node metastasis, the sensitivity is 61 and the specificity is 80. So currently, no clinical role for BET-CT in diagnosis or staging of axillary lymph node in early cancer. But, however, due to its high specificity, preoperative BET-CT have a clinical role in patients with high risk of having lymph node metastasis if locally advanced and having plexopathy and systematic metastasis. What is plexopathy? Plexopathy when the patient have radiation changes affecting the lymph node. So it can differentiate if the lymph node is enlarged because of radiation plexopathy or actually infiltrated. Sampling of the lymph nodes remains the gold standard. Sampling include lymph node dissection, sentinel node biopsy, the core needle and fine needle biopsy, and Bliss and vacuum. Sampling for likelihood of systematic disease and for the need for systematic treatment. We will start by the axillary dissection, which is the gold standard. But the axillary dissection have its significant morbidity of having arm edema, weakness, pain, and cosmetic effect, also associated with the risk of seroma, infection, and lymphedema. The second important is the sentinel node. Sentinel node can to accurately stage the tumor, draining the axillary lymph node, and to avoid the axillary dissection if the patient is negative. Core needle biopsy, we use a core needle biopsy like 2 passes using the 14G needle, positive axillary lymph node in the presence of breast cancer to obviate the need for axillary dissection. That's to say, if it is proven involved by core needle biopsy, we will go for axillary dissection. But if negative, the patient will undergo sentinel node biopsy. So the core needle biopsy is a good method to avoid sentinel node biopsy if pathologically proven before surgery to be infiltrated. And also for clinically and radiologically positive nodes in absence of primary, it is very important to biopsy the lymph nodes. Less than half node positive patient can be identified preoperatively, and negative core needle biopsy and fine needle biopsy does not prevent the sentinel node biopsy. The sensitivity of core needle biopsy when done under ultrasound guidance, 2 passes 14G, is almost 100%. Preoperative sampling using the sentinel node and vacuum is an ongoing research and still have not established role. For clinical impact of this, it's no longer accepted to carry on axillary dissection as a matter of routine without prior biopsy or evidence of pathologically involved axilla. This is an important randomized famous trial, the Z11, axillary dissection versus no axillary dissection in women with image of invasive cancer and sentinel node metastasis. They conducted a study using big number of patients, and the group 1 underwent axillary dissection, and the group 2 without axillary dissection, only sentinel node. And they followed these patients, and they noticed that there were no affection for the patient outcome, and there was low level of recurrence associated with the sentinel node. The sentinel node detects positive lymph node and indicates a higher risk of systemic disease, also indicates the need for systemic therapy. When having additional axillary dissection, it gives the number of nodes involved and unlikely to change the systemic therapy and the cost significant morbidities to the patient. So based on the Z11, the American College of Surgeons randomized the trial, recommends that axillary lymph node dissection did not significantly affect the overall or disease-free survival of patients with clinically T1 and T2 and positive sentinel node. So, do we still, as radiologists, have a role? Do we need to bother ourselves with sampling lymph node? When looking to the recommendation for staging and managing the axilla developed by the National Breast and Ovarian Cancer Center, they stated that unguided axillary sampling followed by radiotherapy, as indicated, provide inferior tumor control. Imaging alone without confirmatory pathology is an unreliable diagnostic test for axillary lymph node involvement due to low sensitivity. Ultrasound confirmed by cytology, either fine needle or core needle biopsy sensitivity approaches 100% and accuracy 93%, but ultrasound alone has a sensitivity or negative predictive value below 80%. A preoperative finding of ultrasound positive node confirmed by fine needle and core needle biopsy might allow the patient to proceed directly to axillary node dissection and obviate the need for unnecessary sentinel node mapping. The MRI still has no currently sufficient data to support the axillary staging by MRI, and the same for PET-CT. This is an example of axillary lymph node sampling in a patient with proven breast cancer, and this is an axillary lymph node from the intramammary lymph node. Here we have an ill-defined mass and with pathologically enlarged lymph node. This to show how we can change the patient management by accurate staging. This case have level 1, level 2, and level 3 axillary involvement. So it is now stage 3B. So I would like to give a discharge teaching point that preoperative imaging of the lymph nodes is very important. Make sure that you check all anatomical sites for staging, and the ultrasound diagnose lymph node infiltration by 2 cardinal signs, the rounded appearance of the node, and the cortical thickness more than 2.3 millimeter. Lymph node sampling is still controversial, but it might change the practice for less axillary lymph node dissection in the future. Thank you for your attention.
Thank you, Dr. Negla, for your outstanding presentation. And now we move on to Professor Pietro Bagnesa. He will present a topic, diagnosis of nephro-related soul